Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta, and for this episode, I'm delighted to have with me today Dr. Sam Finnikin, who's a GP with a special interest in shared decision-making and personalized care. Welcome, Sam.
Morning, Sangeeta.
Can you tell us a little bit more about yourself?
As you say, I'm a GP in Sutton Coldfield, and I also work at the University of Birmingham as a researcher. I've been interested in personalised care and shared decision making for a while now, and applied that to various different topics within medicine and healthcare in order to try and think about how we get the best out of healthcare.
Thank you. And is there something that you're currently researching?
I use routinely collected GP data to explore the way that decisions are made in practice. And so my sandbox, as it were, is statins. So I use statins because it's a really common decision point, statins for primary prevention of cardiovascular disease. And we have a lot of information about it. But also what's really uniquely fascinating about statins is that patients have really strong opinions about statins more than any other medication. So I find it a very interesting area to explore. So I've got a variety of different research projects looking at that area.
Yeah, and there's also been some very recent research on this, on the subject of statins, where more than 90% of statin related muscle symptoms were not actually related to the statin. And so it was more patient perception.
Yeah, it's really difficult to unpick the adverse effects of statins because of the nocebo effect, the opposite of the placebo effect. And people love to blame statins, well, medicines, for everything that goes wrong because it's something external, something that can be changed and something that's easy to fix. Whereas actually, often problems are much more complicated than that. I think statins get a bit of a bad rap, but there's no doubt that some people do get side effects from them. And it's about unpicking those from the nocebo effect. And it can be quite difficult.
And I guess this is where shared decision making plays such a big role. So, how does it actually happen in practice? How do you define shared decision making?
There's various definitions of shared decision making, but for me, it's about thinking about shared decision making as an approach to healthcare, as a way of approaching every medical decision in a collaborative way with the patient. And essentially, it's very basic in its structure and in its components, but undertaking it is much more complicated. And we have to think about this for every decision. And healthcare is full of decision points. It's not just about whether to have a big operation or something fundamental and life changing. It's about whether to take a tablet, whether to have an investigation, whether to go into hospital or not. All these little decisions are as important because they're much more frequent. And fundamentally, shared decision making starts with acknowledging that there are options, and there are almost always options. And when you start at that point, it's very easy and logical then to think about, well, there are options. We need to talk about the pros and cons of each of those options. And then we need to help the patient deliberate on that. And that's possibly the most difficult bit. Think about their individual circumstances, their individual preferences and values, and helping them deliberate on that and the options and the information you've given them to come to a decision about what's maybe best for them.
And what would you say are the biggest obstacles to the shared decision making? Like we know about the system pressures that exist, but are there any other like cultural or internal hurdles as well?
I think about this a lot because I talk to people about the shared decision making a lot of the time, and clinicians, they completely on board with the idea, but then they come up with the yes, but the reasons why it's difficult. And time is one of them. There's no doubt that it's easier just to give someone an off-the-shelf answer, follow a protocol, pick the top recommendation, the guideline. That's the easiest option, and it takes less time. But also, it's cognitively easier. And I think this is the bit that's slightly underappreciated, that shared decision making is much more difficult from a mental point of view. You have to know more stuff. It's not just okay to know what the recommendation is, but you need to know what the risks and benefits of that option is. And so you have to have a much more in-depth understanding of the medicine that you're talking about. And it's actually more cognitively difficult for the patient as well. Patients will often want to have simple answers, but healthcare isn't simple a lot of the time. And we have to talk about the complexities. And that's uncomfortable for people, both the doctor and the patient. Time and the cognitive requirements of shared decision making are difficult. But also, this is a skill, and a skill that, although is embedded in undergraduate and postgraduate curriculums in the UK and internationally, I think that it's not truly appreciated in its depth, because I think that when people go out into the world of healthcare, they don't actually necessarily see it everywhere and they don't practice it, and people fall back onto the more paternalistic and easier way of practicing healthcare, which is just picking the top option on the list, or telling patients what to do.
And how can a GP overcome that 10-minute consultation time constraint and still be able to achieve shared decision making?
It's a good question. And I work 3 days a week in clinic, and I have to do this myself. And it's not always easy. The first thing we have to remember is this isn't an option. I'm not talking about something that is a nice to have in healthcare. This is a fundamental part of how we should be practicing medicine. It's how the GMC say we should do it in decision making consent, their guidance there. It's how NICE say we should be doing it. It's an ethical and legal responsibility to make sure that patients are aware of their options and the risks and benefits of them in order to make decisions. So, firstly, it's not optional. So we have to figure out how, not if, we do this. And the second thing, and one of the great things about being a GP, is that yes, we have these 10 minutes, 12 minutes, 15 minutes aliquots of time with patients at once, but we also have continuity and relationships with patients. And that to me is the shortcut to doing this well, because we're not starting from a blank slate. When a patient comes in, if we work in a practice where continuity is important, if we harness the power of continuity and those relationships, then we're not starting from a blank slate. We know a bit about that person. We might know their family circumstances, their job. We might have discussed before about what's important to them and their preferences. And so a lot of the groundwork is already done, but also they know you. And so you can hit the ground running. And I think that's one of the things that allows shared decision making to work really well in general practice if we throw ourselves into it. And the other thing is sometimes it just isn't possible, but you don't have to do it all at once. In general practice, most decisions aren't immediately pressing for now. We don't have to make this decision now, which hypertensive to start, whether to start HRT, whether to start an antidepressant. These things that we can do the groundwork and say, have a think about it. Here is some resources, some information to have a look at. Let's chat again next week. Or I'll send you a text message saying, have you had a thought? Do you want to chat again? Have you made a decision? So we don't have to make the decision there and then. We can start the process and split it up over time. So there are various strategies, I think, that help us do this in general practice.
What about when a patient has multiple comorbidities? What would your approach then be to finding out the one outcome that matters or the set of outcomes that matters most for that patient?
Yeah, and as you know, this is increasingly the norm, not the exception, that patients have multiple comorbidities and polypharmacy. And this is really where shared decision making comes into its own, because what we're looking at here when we're talking about decisions is applying evidence to an individual circumstance. And we must remember that evidence is based on populations, and often the populations involved in research are not typical of the patients in front of us. They exclude patients with polypharmacy and multimorbidity. And so this is why we have to apply the guidelines, the recommendations with care to the person in front of us through shared decision making. It makes it more complicated because we can't say with any real certainty what the outcomes and risks and benefits are. We have to use our clinical judgment and interpret the evidence based on the individual circumstances of that person. And so it makes it more difficult, but it also makes it more important. If you consider someone living with frailty on 5 or 6 different medications, but perhaps their blood pressure is a little bit high, well, adding another blood pressure tablet might not be the best thing for that person. It might not be what they want. And indeed, the evidence really doesn't include them. And so we have to start thinking about things more holistically and in a more personalized way. But we don't do this in a way that doesn't bring the patient along with us. We have to make sure they're included in and central to the decision-making process.
Yeah. And does this personalized care often lead to less intervention, especially in these people with polypharmacy?
Well, that's interesting, isn't it? Because when you start asking people what they want, what's important to them, very seldom do they want more healthcare. Very seldom do they want more medicine, more interventions, more diagnostics. They want to feel better and they want to live well. But actually, and this is supported by evidence, a lot of people want less. They want less healthcare. And that often doesn't come at the detriment to health. This is the other thing that we need to think about. More healthcare doesn't equal more health. And so if we keep on applying recommendations and guidelines and medicines and treatments to people without thinking about this, we can actually make their lives worse. And some good examples of this are there's research been done in people who have been referred for knee or hip operations, so total knee replacements or hip replacements, when actually, when you talk about the risks and benefits and what's important to them, people, even if they previously decide to have the operation, will actually say, this isn't what I want. This doesn't help me achieve my aims in life. And they choose not to have the procedure. And this is important because A, we're not doing something to that person that they don't want, because that's harmful. But also, we're in a system where all our resources are stretched to the max. And if we're doing stuff to people that they don't want, well, that's a waste of resources where that could be done to someone who does want it. And so it's really fundamental to maximizing the efficiency in healthcare as well. And that's why it's important throughout. It's not just a general practice thing. This is throughout the healthcare system, making sure that the healthcare that people get, the interventions, the diagnosis, are what they want. And if not, we'll do something different.
And you've just said that patients want less healthcare, not more. So, how receptive would you say are patients when it comes to de-prescribing medicines that they already are on? Is there a particular approach that you find successful?
Yeah, deprescribing is important. I mean, you have to remember we're talking patients here as a population. Some patients want more healthcare, some patients want more tablets, but in general, and the evidence supports it, but also in my experience, and I think in probably your listeners' experience, that patients don't like taking tablets. I very seldom get someone sit in my consulting chair asking for more medicine. So deprescribing is a real skill. It takes a lot of knowledge and confidence and is really hard, much harder than prescribing. And this is one of the reasons why we get so many people on a lot of medicines. But again, if you fundamentally come back to shared decision making and talk to patients about the risks and benefits and the options, then it becomes easier, but also more logical. So when patients come to me for a medication review, polypharmacy, I ask them why they're taking their medicines and what they get from them. Because fundamentally, the most important thing is knowing the knowledge about what the medicine is for and seeing how it works. Because some patients might have been told by a cardiologist 20 years ago that if they stop taking an aspirin, they'll die. And you still hear that sometimes, and it's obviously a nonsense. And so we have to unpick that and say, well, you're taking an aspirin to reduce your risk of heart attacks and strokes, but it's not necessary. It's a preference. And if it's causing you problems or actually the evidence has changed or whatever, we can think about stopping that. And then we talk about the risks and benefits. Here's the risks of stopping this medicine. Your blood pressure might go up, or your cholesterol might go up, or you might have more symptoms. But the benefits might be that you don't get the side effects, or you have one less tablet to take. But a lot of medicines we prescribe have no effect in most people. I'm going to say that again because it's fundamental. A lot of medicines we prescribe have no effect in most people, right? And so how do we help people unpick whether the medicine is actually helping them or not? Some medicines that for symptomatic relief, you can say, well, let's give it a go not taking it and see what happens. And we can remind people that all these decisions, they're reversible. Nothing is set in stone. So if someone's taking, say, a gabapentinoid for pain that might have been a real problem, several years ago, but actually they're all right now, but they think they're all right because they're taking the medicine still. Well, you say, well, how about we try reducing it and see what happens? And if the pain comes back, well, we know we've got a treatment that works for you and we can go back up and take the medicine again. But if it doesn't come back, well, that's great. With one less medicine we're taking, and you feel the same. And that can be applied to a lot of symptomatic medicine. Gabapentinoids are a really good example, but things like people on quinine or medicines that have just been prescribed for a long time, and patients aren't sure whether they're taking it for a reason or not. And that's what I ask them. I say, what are you taking for you? And are you sure it works? And if they're not, then we can start there.
That's really surprising that you said that most medicines have no effect on people. So you're talking about these medications that were prescribed at one point for one reason, but a patient has continued to take them for an indefinite amount of time.
Yeah. And even risk reduction medicines, most of them won't have any effect for most people. But that doesn't mean they're not valuable, because we don't know what the future holds. And we don't know if a statin reduces someone's risk of, well, we know that it reduces someone's risk of heart attack or stroke, but on an individual basis, we don't know if it stops that person from having a heart attack or stroke. And that's the real problem with preventative medicine, is that you never realize the benefit. You can only ever realize the harms if you get side effects. I often say when I'm talking to people is no one's ever sat in my chair and said, thank you for preventing my heart attack or stroke, Dr. Finnikin. And yet, probably through the prescribing and advice I've given people, I've prevented hundreds of heart attacks and strokes. But we'll never know. But people will come and complain about their medicines very quickly. It's a really difficult balance. I'm not nihilistic with medicines. I think there's a lot of benefit from some of the great preventative medicines that we have. DOACs are incredibly effective at reducing stroke, antihypertensives, statins, asthma inhalers, all these things, they really do help people live healthier lives. But it's just about making sure we find the balance. And that's why having a good understanding of the risks and benefits of medicine and being able to communicate that to patients is critical.
And now, thinking about when you do nothing or you adopt a watchful waiting approach in shared decision making, how do you frame this to the patient so that they perceive it as care rather than as neglect, or that my GP isn't doing anything? But actually, yeah, how do you frame that?
Yeah, it's a good question. And actually, I'm working with a great researcher from Leicester who's doing a whole PhD on this. And we actually term it not doing rather than doing nothing, because it's an active process of not doing it. It's not passive. And it can be tricky, particularly in things like, whether to admit people to hospital or not. Not admitting them, it might seem like you're not doing something, but we're always balancing those risks and harms. And the first thing, again, coming back to the strengths of general practice, is almost no decision is irreversible that we're dealing with. And we're available, we're contactable, we can make reviews appointments, we can follow people up. And so we can see the impact of our actions and help people, if it's not working for them, then do something different. And that's fundamentally why continuity of care is really important in all of this, and to really embrace personalized care. Continuity of care is important. But yeah, the not doing, that we also have to recognize that clinicians are humans and are subject to all the cognitive biases that our patients are. That real want to help is hardwired into clinicians. We're in the profession because we want to help people, and sometimes it doesn't sit well to not do anything because we feel like we're not helping. And I think that recognizing that heuristic and that bias within us to want to do something and resisting it is important as well. So it's seeing not doing in a more active way rather than a passive and negative action is important. And not doing is really important. Not doing those tests, not doing that referral, not doing that prescription, and just seeing how things go. The real example in this area that I use when I'm talking about this is antidepressants in mild to moderate depression. We know that they're not hugely effective, and certainly no more effective than other treatments, lifestyle improvement, exercise, counseling. And so I have a personal heuristic, I suppose you could say. It's not hard and fast, but I don't prescribe antidepressants the first time I talk to someone. I'll talk about them and offer them, but I don't prescribe them. I'll follow them up, and we'll do that kind of split consultation that I talked about before, because almost always the second time they feel better. Things have improved, and that's because of a variety of things. Talking to you, maybe taking some action that you've come up with, but also regression to the mean. People come to you at their worst moment often, and things can just naturally get a bit better. But if you started an antidepressant on that first appointment, you're then down a road of 6, 12 months of medications, follow-up appointments, review appointments. And actually, when we talk about efficiency and the time taken for shared decision making, if you just go for that prescription, reach for that prescription pad, what you've done is created a lot more work for you and your patient, when actually things probably would have got better anyway without the medicine, and it would have been a lot more efficient and cheaper for the healthcare system and better for the patient if we just didn't do something and we just gave it a bit of time and followed things up.
So there's a lot of value in that as well. And in your experience, what's the best way that you found to communicate risks associated with any kind of intervention or medication to your patients?
So risk communication is a fundamental skill that all clinicians should have and is a necessary part of shared decision making. We've talked about risks and benefits. And so it's also an area of research. There's a lot of research in risk communication. And because I'm an academic, it's something that I'm interested in and have looked at. And there are a few things I would take away from risk communication research. Firstly, is that people are different. People are different in how they understand information, how they want to receive information. And so if we use a variety of different ways of communicating risk, that helps. We tend to think that using absolute numbers are better than percentages. So saying that 20 out of 100 people might get this side effect, or 30 out of 100 people would benefit from this medicine, but also giving negative and positive framing. So you say 20 out of 100 people might get this side effect, which means that 80 out of 100 people won't. So you let people see. When we're using natural frequency, we try and keep the denominator the same. So we wouldn't say 1 in 10 people benefit from this medicine, but 20 out of 100 people get a side effect, because then you're changing the denominator, it makes things confusing to people. And then if you've got some recourse to visual representations, whether it be a patient decision aid or a decision support tool, or even the inbuilt tools in apps and websites that allow us to create Kate's plots, then that can be helpful to some people to visualize the risks and benefits. And those are the kind of things I try and send to patients in between appointments so they can take time looking at them, because doing it in the appointment can be quite tricky. But all this stuff is in the NICE shared decision-making guideline. Many people don't know the shared decision-making guideline NICE, but it's in there, how to communicate risk. So people can have a look at that. It's a great reference. It's like a how-to guide rather than a traditional guideline.
Speaking of some patients who don't want to take decisions themselves, how would you encourage autonomy and help that patient make a decision regarding an intervention?
I think this is a really tough question. I think it's one we haven't truly grappled with as a society, as a healthcare system, or as an academic body. It's about responsibility in healthcare. And I possibly run the risk of misspeaking here or maybe being an outlier, but I'm not sure whether a competent adult should be allowed to not take responsibility for their healthcare decisions, because ultimately they are responsible for their health. We as healthcare professionals and as a healthcare system are not responsible for people's health. And so when it comes to making decisions about an individual's health, it has to be the person who makes that decision. The law is very clear on this. No one can make healthcare decisions on behalf of a competent adult. The only kind of caveat to this is that an adult could say, well, my decision is to go with your recommendation, whatever that recommendation is. So that's a way around it. They're making a decision, but it's the doctor's making the decision, essentially. And that's a tricky one. And I think that when that happens, a lot of people I talk to will say, well, this is all very well and good, Dr. Finnikin, but my patient will just say, well, what do you recommend? Or what would you do if you were me? And it's really common. I get it in practice all the time. What I try and encourage people to do is turn that back round and say, well, this is your decision, and I'm happy to give you a recommendation, but I want to make sure that recommendation is right for you and your individual circumstances. So let's talk about what's important to you and what you think about the options, so that I can then give you a recommendation that is best for you. And in that way, we are still doing shared decision making, even if the ultimate recommendation is coming from you as the clinician, because we're not just giving the off-the-shelf protocolized answer, we're incorporating what's important to that person into the recommendation.
And in case there are cultural language barriers, how does shared decision making work in such circumstances?
Well, it makes it a lot harder. Ultimately, when you work with people from different cultures, you start to understand, I think, some of the different approaches to healthcare. Some cultures are more paternalistic, some cultures are more consumerist. Some cultures, I do quite a lot of work with China at the minute, and what's interesting in a lot of Chinese culture, particularly with elderly patients, is the family will often make the decision and exclude the patient entirely from the decision making, which is very uncomfortable for me. So it's understanding where different cultures are coming from, although acknowledging that people can be from a culture but have a completely different approach. And you've got to do your best to try and work in personalized care and shared decision making. Because as I said previously, it's not optional. We have to try and do it. But language is tough. because one of the things about shared decision making is getting to know your patient. And that's not in the formal history taking, and it's the chatting around the edges. It's the small talk that helps us build that relationship. And I find that really difficult through an interpreter or through someone where English isn't the first language and we're struggling to communicate. So it is more difficult. Keep trying.
Thank you. And a final question, Sam. If GPs could make one change that would improve personalized care for patients, what would it be?
Remembering there are options. There are always options. And just being confident enough to not just go with what the NICE recommendation is. So this might be a bit of a long-winded answer, but NICE and other guideline producers make recommendations, but they're not set in stone. And if actually you look at NICE guidelines, and I encourage everyone to look at the first page of NICE guidelines, there's a bit that says your responsibility. As a clinician, your responsibility. And it says in there, it is not mandatory to apply these guidelines. It says very clearly you should know these guidelines and that you should understand these guidelines, but you have to apply them with care to the individual circumstances of the patient. So the NICE guidelines themselves say you don't have to follow the guidelines. You have to know them and apply them. That's our responsibility. And so being confident enough to say the guidelines might say this, but for this person, another option might be better. And using those options and explicitly stating there are options and then talking about them to the patient. So it's just fundamentally remembering that there are options.
Interesting. And thank you so much, Sam. And I'm sure our listeners will really appreciate all of these insights that you shared today. And thank you very much for listening. This episode was produced by Jude Owen. Don't forget, you can claim CPD certificate for this podcast if you head over to the MIMS Learning website at mimslearning.co.uk. And do join us next week for our next episode. Thank you.